Good morning, everyone. And today we are going to start one more topic. We are still discussing the myeloid lineage of on myeloid disorders, and in that one, like the first one, which we have already covered, is acute myeloid leukemias. And today we will have a short discussion about myelodysplastic syndromes, and then we will move on chronic myeloid leukemia. As you can see, myelo means myeloid lineage dysplastic syndromes. Now, again, to tell you, there is the classification which I was talking about, acute myeloid leukemia as well. This one also have a huge classification or long classification, which was given in 2008 by WHO. 2008 classification uh, by WHO. Okay, for myelodysplastic syndromes. Again, uh, what you are going to find is like when you will see this classification, it's a very uh, long classification. For example, there is uh, refractory cytopenia with uh, unlineage dysplasia, in which there is cytopenia and there is anemia, which is refractory, where there is neutropenia, which is refractory, where there is thrombocytopenia, which is refractory. So we say refractory means like anything which is not responding to any kind of treatment. Okay, then there is refractory anemia with ring sideroblast, refractory cytopenia with multilineage dysplasia, refractory cytopenia with multilineage dysplasia and ring sideroblast, and refractory anemia with excess blast cells. So simply, what you can say, there is a lot of what you can say things which come under this classification. The point here is it's very hard to remember this classification. So what I would suggest is like if you will understand what is this disorder, uh, then it will be better to understand what kind of condition this is. So myelodysplastic syndrome is a heterogeneous or group of disorders. Okay, so it is a heterogeneous group of conditions or disorders or group um, of malignant stem cells disorder. Okay, like heterogeneous means like there are many conditions which come under this thing. Now it is character characterized by um, dysplastic dysplastic and ineffective. Okay, dysplastic and um, dysplastic and ineffective, what you can say, cell production, right? So the cell production is going on, but the cell production is basically dysplastic, which is ineffective. Okay, what is dysplastic now? The important is dysplastic or dysplasia, of course. So dysplasia, uh, like the exact meaning is like difficult or you can say bad formation of the cells. Okay, so simply dysplasia or dysplastic is simply abnormal growth or development of cells. Okay, so whenever there is abnormal growth and development of the cells, of course their function will not be normal, their histology will not be normal, they look abnormal, their functionality is abnormal. So of course, like there will be, what you can say, a lot of abnormal cells in the body which cannot function, and that's the reason we call it as dysplastic and ineffective um, blood cell production, right? Blood cell production will be there. So in this syndromes, the cells which are formed are dysplastic. They are ineffective blood cells. Okay. So uh, production. So which results in, you can say, which results in or uh, peripheral cytopenias, like simply the cells are uh, decreased, okay, in the periphery or in the circulation. Uh, and one more thing is what, and there is, you can say, risk of transformation into acute leukemia, right? So now, what is important thing, like myelodysplastic syndromes can give rise to acute leukemia simply, um, and these abnormal cells which are circulating in the peripheral blood, like, or in the blood, basically they cannot function properly, okay. And the thing is, in myelodysplastic syndromes, the immature cells, they started appearing in the bone marrow, in the peripheral circulation. And what happened, like, in the start we don't found any symptoms in these patients, but later on, of course, like, what happens is, they can change into like acute leukemias, okay. And of course, when they change into acute leukemias, as I told you, acute leukemias are more like dangerous, and they have like, they can kill the patient, or they can prove fatal if no treatment is provided in time, especially to these patients, right? So what is happening in myelodysplastic syndromes is like, the ineffective hematopoiesis which is going on. Ineffective hematopoiesis, like the formation of the blood cells, right? Uh, like, when we check their bone marrow out, or when we do a bone marrow biopsy, what we found is, uh, in the bone marrow, uh, there is a lot of cells which are present, or usually you can say the bone marrow is hypercellular, okay. So like, what we found in these patients is there is ineffective hematopoiesis, okay. Hematopoiesis is there. So hematopoiesis is going on, okay. But when we see their spinal bone marrow, what we found is like there is adequate number of uh, progenitor cells, okay, or like the cells which give rise to different type of cells, right? So when we see their bone marrow, there is adequate number of progenitor cells, okay. So what it means, like, when you are going to see the bone marrow is hypercellular, okay. There are too many cells which are present in there, okay. So but when hematopoiesis, which is ineffective, okay. So these like, all the cells are present and they are doing hematopoiesis, but the hematopoiesis are not ineffective, is not effective, you can say. So what, like, the final cells which are formed by this one, they have a lot of qualitative, like the quality or the functionality uh, is not good. So they all have qualitative functional defects in them, right? So uh, the important thing, myelodysplastic syndrome, see, dysplasia is there, or so the formation of the cells is bad. Uh, so what is happening? The hematopoiesis is still occurring. Okay, the hematopoiesis is not stopped, so but the hematopoiesis is ineffective. When we are going to see their bone marrow, we found adequate number of cells, or you can say the bone marrow is hypercellular. But when these cells, they differentiate, or they grow up, they have many qualitative functional defects which cannot function properly, okay. And that's what the definition says. See, heterogeneous group of malignant stem cell disorders characterized by dysplastic and ineffective blood cell production, which results in peripheral cytopenias, and there is risk of transformation into acute leukemias. So, what you can say, uh, like, this is the presentation of this condition, right? So, what you can say, um, simply, not all of them, they can develop into acute leukemia. Basically, the risk is, you can say, less than 30%, okay. Like, in less than 30% patients, it can lead to develop into what kind of leukemia? Of course, acute myeloid leukemia. okay, which we have already covered. So many of the dysplastic syndromes, they can change into acute myeloid leukemia, okay, when they will start producing some sort of blast cells and they will start appearing in the blood, we will say that the patient have acute myeloid leukemia. Okay, so the risk factor for this condition is simply, again, this myelodysplastic syndrome is again a condition of the old age. Okay, so elderly people are the affected, are mostly affected. Sorry, okay, they are the mostly affected. Other risk factor is like post chemotherapy. Uh, Again, exposure to different things like benzene, tobacco, radiations, same things, no difference, and genetic abnormalities, okay, maladies. Like this is the same thing, guys, which I explain you in general, or what you will see in acute myeloid leukemia. They have the same things. So again, like it is a condition which affect mostly elderly, or you can say people over 60 years of age, right? So it's a disease of old age. Not like this cancer occurs in most of the old people. So most of these patients who have this thing, they are asymptomatic, okay, uh, because we don't see much symptoms until and unless, like, or even the symptoms when they develop, they are very slowly, okay. So most of the patients are asymptomatic at diagnosis. And why? Because many of the times in developed world, it is diagnosed on routine investigations when they found anemias or thrombocytopenia or neutropenia, okay. And then when they keep on checking why this condition is there, so they found uh, like the patient have this condition, okay. So for example, like CBC is a very general investigation, and many people, they had CBC for multiple conditions. So when they go for a CBC, they found they have anemia, they have thrombocytopenia, or they have neutropenia. And then when they investigate more, they found that the patient have this thing, okay. So one of the thing, guys, if you remember, we had done microcytic anemia. So myelodysplastic syndromes can also cause microcytic anemias. Okay, so uh, whenever like the symptoms, for example, they started like appearing, of course, the symptoms are the symptoms of anemias, the symptoms of bleeding, the symptoms of repeated infections, like as you know why. Okay, uh, so they present with these symptoms. So as I told you, like most of them, they are diagnosed like when they are still in their asymptomatic stage. So of course, like we can do CBC, and in CBC, what you will find, you are going to find anemia, you will find thrombocytopenia, you are going to find neutropenia, right? This is how they present. And then, of course, like once we found that, we do the peripheral film to see like how the cells look like, okay? And in this one, when we do the peripheral film, guys, as I told you, RBCs, they are usually macrocytic. Okay, like that's why I told you MDS is also a cause of macrocytic anemia. So in this one, basically the RBCs are big and they are oval in shape. So that's why RBCs in this case is called as macro uh, ovalocytes. Okay, so they are called as macro ovalocytes. And when we see the reticulocyte count, it will be low. Okay, so WBCs, when we will check, of course, like they will be decreased, and like they also have abnormal pathology. Like one of the thing which I would like to mention is like they are bilobed. Uh, they have bilobed, unsegmented um, nuclei. Okay, nuclei is there. So it is also called as Pegler's abnormality. Pelger's, Pelger abnormality. So when you will see the platelets, of course, they will be decreased as well. And again, platelets have, like I'm talking about the peripheral film, what the platelets looks like. The platelets have are giant, hypogranular, less granules are there. Okay, platelets will be there. So this is how they appear. Then remember, like in all these conditions, what we can do is we can go for bone marrow biopsy, right? So we can take a bone marrow aspirate and we can see, like, we can do a biopsy simply, and we can see what kind of cells are there. So what this condition will show, if you remember the definition, the bone marrow will be hypercellular. Okay, it could be normal cellular, but mostly it is hypercellular, uh, with dysplasia or dysplastic changes. You are going to see. Okay, this is the thing. And like rest of the things is, like, in the start I told you, to classify what kind of myelodysplasia is there, a dysplastic disorder is there. We are going to check for cytogenetics, immunophenotyping, and I'm not going to write everything over here, but all these things which I talk about in the starts, like how they classify different leukemias, is like they have to run a lot of investigations. Well, like in many of the patients, they found like there is either partial or total loss of chromosome 5 and 7. Okay, so, and many of them, they have multiple abnormalities as well. So like this is myelodysplastic disorders in general, and how they treat these patients is the treatment is simply depending on the condition of the patient. Okay, how either they are low risk or either they are high risk of transformation. For example, like on investigation, they decide either the patient is having, you can say, low risk of transformation into to acute leukemia. Okay, or either the patient has high risk of transformation to acute leukemia. Okay, so uh, based on this thing, we decide like either they need some treatment or not. Okay, so anyone who have low risk of transformation to acute leukemia, what they do is, of course, after running all the investigations, they come to know about this thing. So one thing which they can give to low risk patients is like erythropoietin stimulating agents, EPO. Okay, EPO can be given, epoetin. So, uh, like to tell you the truth, I don't think so. Like you are going to found these kind of questions in any kind of basic examinations. Okay, so erythropoietin stimulating agents are given. So what is this one like? Just to start, effective erythropoietin, like erythropoiesis, simply red blood cells, because they have refractory anemia and all this stuff. Okay, so of course, like we give this thing. Uh, why we give this one? Because to start more and more effective erythropoiesis, or if the patient is not having a effective erythropoiesis, of course, uh, they develop anemia, they develop thrombocytopenia and all this one. So we can give them transfusions, by the way, but transfusions are given whenever their cells count is going to be decreased. So this one is given to reduce the, you can say, the requirements of transfusions in these patients. Okay, especially the patients who have they found deletion in chromosome 5. There is a drug called as um, lenalidomide. Okay, this drug can be given to these patients. Okay, and rest is all supportive care, of course, like because these patients, they need repeated transfusions. Okay, so Same thing if you know about hemochromatosis or thalassemias, in which like we give repeated transfusions. So what happens, like there can be risk of iron overload, so we keep on giving them uh, you can say iron chelation therapy. Okay, so of course, like think about thalassemia, in which, or all the conditions in which like we need the patient is needing multiple transfusions every week. Okay, because it depends on the cell count, either the cell count is very decreased or not. So high risk are those who have increased risk of transformation to acute leukemia. Okay, uh, so what is done in them is like supportive care. Of course, it is given whatever is the symptoms, treat them. Okay, fevers or anemia or thrombocytopenia. So if the patient age is less than 65, in developed world, of course, they uh, go for stem cell transplantation. Okay, so like of course that is going to solve the problem. Um, but if the age is more, then what they do, they give them, it is called as epigenetic therapy. Okay, they give them a DNA methyl transferase inhibitors. Okay, inhibitors. So uh, there are, what you can say, a lot of drugs, which are there, uh, like which are basically DNA methyl transferase inhibitors, right? Uh, so, what is epigenetic therapy, by the way? Basically, these are the drugs, uh, which which have that ability to, you can say, influence the epigenome. Okay, so what is epigenome is like the chemical changes of the DNA. Okay, the, or the proteins in anyone. Okay, so this therapy basically can modulate or can change them. So simply this, of course, like very new type of therapy. So DNA methyltransferase is a type of epigenetic therapy. Okay, so these inhibitors we can give them. For example, one of the name of the drug is called as 5 azacitidine. Okay, so this can be given. So this is the treatment, and rest is like all supportive care, which can be given to these patients. So the prognosis of this one, uh, like like they see the prognosis of these patients based on RIPSS, okay, which is revised international prognostic scoring system. Okay, I would rather write it, revised international prognostic scoring. Sorry, international prognostic scoring system. So this one is called as so basically this one is written like this way: international prognostic scoring system dash revise. Okay, so it is revised international prognostic system, and basically this is the system which we use to classify that the patient is low risk or high risk. Okay, so uh, what is done in this system is like they check the cytology, they check the percentage of bone marrow blast cells, they check the hemoglobin, platelets, and the absolute neutrophil count. So there are five, you can say, five factors are seen, right? Five factors are checked by this system. What are the five factors? Cytology. Uh, then they check the percentage of blast cells. Okay. Uh, then they check, what you can say, the hemoglobin levels. Okay. Hemoglobin levels. They check the platelets count. Platelets count. They check the absolute neutrophil count. Neutrophil count. Okay, so these are the 5 things they check, and they decide either the patient is a high risk, very high risk, low risk, and if they want to count the prognosis, like if you want to calculate the prognosis of the condition, again they follow this 5 point international prognostic scoring system revised. And for example, a very low risk patient to change into acute myeloid leukemia have a very good outcome or prognosis, but whereas the patient who is a very high risk of changing into acute myeloid leukemia, they have the least or the worst prognosis. Okay, so this is how they calculate this thing. Okay, after that, uh, if you remember this thing, this one. So we had done this thing. We had done this thing. Now we will go on myeloproliferative disorders. Okay, or in this one, the most important is CML. So uh, you can say in this one, which we will go through, is myeloproliferative disorders, right? So uh, myeloproliferative disorders, guys, by definition, um, see, we we were studying myelodysplastic syndromes, right? So now we are going into myeloproliferative, okay, disorders or neoplasms, okay. Now, see, what is the difference? Myelodysplastic syndromes have ineffective maturation, okay. Simply what we were studying this one, okay. As you can see the definition, the the bone marrow is hypercellular, but uh, the cells when they get mature, they are they have qualitative functional effects, okay. So you can say it have what it is, basically ineffective um, maturation, okay, of the cells. In What are myeloproliferative disorders is uh, proliferation is going on, right? So there is overproduction of what you can say mature cells, right? So this is the main difference between myelodysplastic and myeloproliferative disorders. Okay, one have ineffective maturation, and one have ineffective overproduction of mature cells, right? So this one, of course, like this is myeloid lineage disorder. Okay, so the cells or clonal stem cells in the myeloid lineage, okay, myeloid stem cell abnormality is there, okay, which leads to um, overproduction, okay, of one or more cell lines, okay. Uh, so this is simply the definition of myeloproliferative disorders. It could be erythrocytes, it could be platelets, it could be neutrophils, it could be basophils, it could be eosinophils. Again, myeloproliferative disorders is also disease of old age. Okay, so mostly you will see these patients in their 60 or 80 years of age, right? Uh, like this is the age group where we will find most of the patients. Uh, okay, now, that one in myeloproliferative disorders, or myelodysplastic disorders, they are the one which can change into uh, acute myeloid leukemia. Uh, this one can, what is the fate of these conditions? Like, number one, they can change into acute myeloid leukemia, okay, and they may develop uh, marrow or bone marrow fibrosis, okay, uh, bone marrow fibrosis with time, okay. Like when the bone marrow is fibrosed, guys, the bone marrow cannot produce any cells, and of course, like what is going to happen is like there will be no cells in the body. Okay, so as you remember, like in this one, there is conditions like Polycythemia Vera. Okay, then one condition, these 4 conditions I'm talking about. Polycythemia vera, essential thrombocythemia, chronic myeloid leukemia, as well as idiopathic myelofibrosis, right? So, see, uh, of course, like I'm not going to, we are not, okay, we can, by the way, discuss each of them one by one, but all of them, they have, they are related to some genetic abnormality. All of them, they are related to some genetic abnormality. Okay, uh, all of them, they can give splenomegaly. Okay, except essential thrombocythemia, the rest of three can give hepatomegaly as well. But this one, which is idiopathic myelofibrosis, usually give more fibrosis of the bone marrow. Okay, these can also give, but this one surely give. These three can give, or sometimes it don't give. Okay. Uh, Now, see, essential thrombocythemia, of course, there will be increase in platelets count, right? Polycythemia vera, many of these patients do have platelet count will be increased, right? Um, WBC count, for example, will not be there in essential thrombocythemia because this one is related to the platelets, whereas the rest of the three can give increased WBC's count as well. Okay, whereas in essential thrombocythemia, you can say the only the platelets will be affected, no WBCs will be affected, no what you can say other cells will be affected, right? So we are discussing about chronic, we will discuss chronic myeloid leukemia. As you can see, uh, what is the definition of this thing? It is a myeloproliferative disorder characterized by increased proliferation of what? Uh, Granulocytic cell line without the loss of their capacity to differentiate. See, uh, it's a chronic condition, slowly evolving condition, right? It is characterized by increased proliferation of granulocytic cell line. Again, guys, like you, I take you again and again on this one, right? So, uh, this one have like the cell line, which is the granulocytic cell line, it will be disturbed, right? And they are going to form more and more and more cells, right? Whereas what you can say uh, in essential thrombocythemia, for example, only the platelet cell line will be the one which is going to be abnormal. So myeloproliferative disorder characterized by increased proliferation of granulocytic cell line without loss of their capacity to differentiate. So see, they are differentiating normally. In myelodysplastic disorders, they are not differentiating normally. Here, the cells will be overproduced. There will be over number, or there will be increased number of mature cells in the blood, but the cells, they did not lose their capacity to differentiate. They differentiate normally. Epidemiology occurs in any age group, mostly middle age to elderly, with a median age of 65 years of age. So it means it is also a condition of old age. Now, very important. See, what is the hallmark of acute myeloid leukemia? That is iron rods. Guys, one point which I will suggest you to remember about this one, high chances that it can be asked in any type of exam. Uh, Pathophysiology, whenever you found that the patient have Philadelphia chromosome, okay, what is Philadelphia chromosome? It is basically a translocation between chromosome 9 and chromosome 12, right? I have all the photographs in this slide. Wait, I have to found it basically. Just AML, IR rods. Remember this thing? IR rods, IR rods. Okay, these are IR rods. You can see over here. Okay, whereas you can say this is like all the photographs of AML, which I did not show you because um, there is no point, right? So M4, M5, M5B, M6, M7, megakaryoblast. Okay, acute lymphoblastic leukemias. No, not this one. Chronic myeloid leukemia. Yes. Uh, okay, no, there is no photograph for this thing. Okay, so simply, guys, it is a translocation. Okay, these patients, who have chronic myeloid leukemia, they have a translocation between chromosome 9 and 12. Okay, so whenever there is a translocation between chromosome 9 and 12, we call that thing as Philadelphia chromosome. Okay, because basically there is a proto-oncogene which is translocated from chromosome 9 to breakpoint cluster region, BCR. BCR is breakpoint cluster region of chromosome 22 to produce what? BCR cluster region dash ABL fusion gene and active tyrosine kinase. Okay, so whenever this active tyrosine kinase is there, so this is the one which is causing all the issues with this thing. So guys, read this one carefully. Detection of the BCR-ABL fusion gene is a diagnostic test for CML present in over 90% of the patients. So once we found Philadelphia chromosome in any patient, done, the diagnosis is done that the patient have chronic myeloid leukemia, right? Clinical features. It have three phases. One is called as chronic phase, then there is accelerated phase, and then there is blast crisis, okay? And as you know, what is blast crisis? Presence of too many blast cells in the bone marrow. So we will go one by one. In chronic phase, basically most of the patients who are diagnosed, they are diagnosed over here 85% of the times. There are very few blast cells, less than 5% in the peripheral film, which is quite normal. Plus minus can be or cannot be slightly elevated eosinophils and basophils, because remember, this is a problem, or this is a condition which affects the granulocytic lineage. Okay, and this is the phase when there is no significant symptoms or the patient is basically asymptomatic, right? So guys, chronic phase is basically an asymptomatic type of phase. Then there is an accelerated phase. What is accelerated phase? There is impaired neutrophil differentiation. And what we found? We found circulating blast cells. Now, see, pay attention over here. Circulating blast cells here is around 10 to 19% in the blood film, because when it is more than 20%, we name or we label the condition as acute or blast crisis. So, see, the cells in accelerated phase are increasing, and more cells will be present in the peripheral blood film. But uh, what is going to happen? Like there will be increasing basophils in the body, which will lead to pruritus. The patient present with pruritus, and uh, when you will check through CBC, you will find thrombocytopenia. The platelets will be decreased. Uh, there will be cytogenetics evidence of clonal evolution, and worsening constitutional symptoms and splenomegaly can be there. Okay, which shows extramedullary hematopoiesis. What is going on? And now the erythropoiesis is not just going on in the bone marrow, rather it is also going into the spleen, which means like the spleen is going to enlarge, right? So acute phase or chronic phase, uh, few blast cells, no symptoms. Asymptomatic phase, accelerated phase, now the neutrophils, they started differentiating more and more and more. When the basophils will be increased in the peripheral blood, the patient can result into pruritus. So then there is a stage of blast crisis. It is more aggressive disease. Blast cells fail to differentiate. The blast cells will be present more than 20% in the peripheral blood or bone marrow, and simply this is the time when like the patient is in acute leukemia phase. Okay, so 1/3 going to ALL, 2/3 going to AML. Okay, so basically, like these are the three phases, but the clinical presentation is different. See, 20 to 25% of the patients are asymptomatic when diagnosed. Okay, like because they are diagnosed on CBC or peripheral blood film, and they don't have any specific symptoms, or you can say they have non-specific symptoms like fatigue, weight loss, malaise, excessive sweating, and fever. But when their spleen is going to involved, their spleen become big, they may have left upper quadrant pain, early fullness, okay, or abdominal fullness can be there, and they complain of shoulder tip pain, which is a referred pain because of splenomegaly. And one more thing, see, splenomegaly is one of the most common physical findings in patients of CML. They can present with anemia, they can present with bleeding because of platelet dysfunction, they can present with pruritus because of increased level of basophils. Increased level of basophils is going to give you increased level of histamine. Again, the same story. Leukostasis. I explained you this thing already. What is leukostasis? Due to increased number of blast cells in the body, guys, it can lead to encephalopathy. It can lead to priapism. It can lead to a lot of issues, right? Because of increased level of blast cells in the blood. Okay, so see, the, the clinical features which I'm discussing in this one, or which I discussed in the first lecture. First lecture is very important. Uh, all these conditions, these conditions will keep on repeating. There will be no difference at all. Uh, so see the investigations now. What we will found in the investigation, see, of course, the WBCs will be raised. It is a problem with granulocytic lineage. There will be decrease of normal RBCs. There will be increased or decreased platelets. There will be, of course, increased basophils, right? And when you are going to check the peripheral blood film, okay, uh, what you will see is like leukoerythroblastic picture. What is leukoerythroblastic picture? Basically, what we found is immature red cells, leukoerythroblastic picture. So, erythroblast, immature red blood cells, and leukogranulocytes will be present. For example, myelocytes and normoblast, right? So, this is called as leukoerythroblastic picture. We will see. Uh, and if they are changing into going into acute myeloid leukemia, you are going to find very too much mid-stage progenitor cells. What is mid-stage progenitor cells, guys? Simply, this photograph is not clear, so like maybe you will find a lot of these cells, right? Like mid-stage, not blast, not fully mature, but in the middle, right? So you can find a lot of you can say a lot of cells in this stage, right? When we check the bone marrow of these patients, what we will found is myeloid hyperplasia. By the way, this one should be like this, okay, and this one should be like this. Should come under this, and so uh, we found myeloid hyperplasia with left shift. Like, what is left shift? Like, there will be increased megakaryocytes and myelofibrosis. And molecular cytogenetic studies of bone marrow or for Philadelphia chromosomes we can do, which is that diagnosis. I told you it is a translocation between chromosome 9 and 22. Okay, and you can do abdominal imaging for a spleen size, like ultrasonography can be done, physical examination can be done, CT scan can be done. Okay, just to see like how much spleen is enlarged. Uh, treatment for this thing, guys. Uh, of course, when the patient they are symptomatic. Okay, sorry. When the patient they are symptomatic, uh, they have pruritus, give them antihistamines. They have increased uric acid, give them allopurinol. Okay, this is one of the conditions which have like good response. Why? Because uh, what is the condition? What is why this condition is arising? Tyrosine kinase. Okay, tyrosine kinase. You can see over here. This gene is basically an active tyrosine kinase, which is an enzyme. Okay, what is going on, by the way? How we what you can say, how we can treat it, because we know what's going on. Okay, so uh, once we are going to what you can say control that thing, of course, we can control the condition. Okay. So as you know, tyrosine kinase is an enzyme. Okay, whenever there is A, it means it's an enzyme. So uh, tyrosine kinase is an enzyme. Uh, Basically, you know, when tyrosine kinase is there, the function of this tyrosine kinase is simply uh, to produce more and more and more and more cells, right? Again, like not so like I'm telling you in very simple words, but simply like of course there is a big chain or functionality of this enzyme, you know, which can lead to this thing. So what we can give them is one of the drug is called as imatinib. Okay. By the way, I will change it the, to uppercase. Imatinib. It comes by the name of Gleevec, internationally very famous brand. Okay, it comes by the name of uh, Gleevec. Okay, it inhibits proliferation and induce apoptosis by inhibiting tyrosine kinase activity in cell positive for BCR ABL. Okay, so uh, this thing is important, and you can say if loss of response or intolerance, okay, is there, for example, uh, to imatinib, we can give a trial of second generation drugs, you know, like dasatinib or nolotinib. Okay, it's not nolotinib, it's nilotinib. Okay, it's nilotinib. Okay, so simply when this is the first generation, if this is not one is not working, we can try a second generation tyrosine kinase inhibitor or a third generation tyrosine kinase inhibitor. Okay, uh, so this is the first line treatment, guys. All this one is the first line treatment. If imatinib is not working, we can change the second generation of or the third generation tyrosine kinase inhibitors. Uh, Interferon alpha. This is alpha, you know, because I don't know how to make this symbol. So it is interferon alpha can be given. So because you know they improve the response of tyrosine kinase inhibitor. Okay. Uh, Basically, you know, this one is nowadays not much used like interferon A. Okay. But nowadays you can say this is only used for pregnant patients. Okay, pregnant patients. So interferon alpha basically it improves the you can say uh, response of tyrosine kinase inhibitors. So when we give this drug with this drug, you know, the effect is good. But nowadays, you know, we don't use much this one because nowadays these drugs are available, which are tyrosine kinase inhibitors. So this one is used for only pregnant patients. Okay. Uh, when the uh, patient, you know, palliative settings, you know, anyone in which the disease cannot be cured, rather, we just have to control the symptoms to give the patient a easy life, or we know that the patient is going to die, but we just have to make his life easy. We can give them what you can say hydroxyurea. Why? Because it reduce WBCs, right? So basically, it improves the encephalopathy and all those things. Okay. Uh, Bone marrow transplantation if progression to accelerated or blast phase crisis, of course, CML is curative, right? So what is the treatment? Okay, this is all the treatment of chronic phase, and then what is the treatment of accelerated phase or blast phase, guys? Like, of course, the thing will be same. Uh, so the first thing, like we refer for clinical trial for second or third generation TKI, like nilotinib or dasatinib, right? We can give that. TKI is like tyrosine kinase inhibitor, and prepare them for allogenic stem cell transplant. Okay, the ultimate. So if the patient is in blast phase, okay, typically get AML induction therapy, which we have already discussed, okay? How we induce induction in patients who have acute myeloid leukemia. So like whenever there is a blast crisis, we change the treatment line to how we treat the patient of acute myeloid leukemia. So of course, stem cell transplantation may be curative to be considered in young patients and do not meet therapeutic milestones, okay? Because stem cell transplantation is the best thing you can do to these patients. And uh, treatment success is monitored based on the therapeutic milestones. What are the milestones we have to achieve? Hematologically, improve WBC and platelet counts and reduce basophils, and cytogenetically, undetectable Philadelphia chromosome in the bone marrow, and molecularly level, reduction or absence of BCR-ABL genes or transcripts, in periphery. And so, like these are the goals, you can say. Okay. By the way, we can sorry, we can write over here treatment goals. Okay, treatment goals. Like if we are achieving these things, of course, like it means like treatment goals we have achieved. Okay, so if you found that the patient have improved WBC count, platelet count, reduced basophils, no Philadelphia chromosome, and no abnormal gene is present in the periphery, of course it means like you have achieved the goal, right? The last thing is prognosis, guys. uh, the prognosis of this condition, like survival dependent on response. Those achieving complete cytogenic response on imatinib by 18 months of therapy, 6-year overall survival is more than 90%, which is very good. So anyone who is responding, is giving response to imatinib, their prognosis is very good. And those who do not achieve complete cytogenic response on imatinib, overall 6-year survival is not good. So you can say the prognosis depend on how the patient respond on that drug. Okay. Anyone who is in acute phase of blast crisis, usually within 3 to 5 years, 2-3 of them, they develop AML, and 1/3 develop ALL. Of course, I told you this thing before, right? So this is all about what you can say. Uh, this one, chronic myeloid leukemia, right? Guys, like uh, polycythemia vera, I just want to finish like this lecture on uh, discussing polycythemia cythemia cythemia vera. I'm sure, like when we start medicine, especially studying what you can say in physiology, polycythemia they teach us, right? So, what is polycythemia? There will be increased production of RBCs, right? Plus minus increased production of WBCs or platelets. Okay, but like this one, uh, again, it have a very what you can say extensive type of WHO classification. Okay, so to diagnose polycythemia vera, there's a major criteria in which like the hemoglobin level, like we say like the HB level is greater than 185 gram per liter in men, or greater than 165 um, gram per liter in females, okay, or in women. This is one of the major criteria to diagnose what you can say polycythemia vera. One of the major criteria which is there is called as presence of a what you can say JAK2 V617F. Okay, uh, this is also called as JAKM2 mutation. So you can remember it like JAK2 mutation, right? So this is like these two are the major criterias, okay, to diagnose what you can say polycythemia vera. The minor criteria is simply like they go for bone marrow biopsy, okay, and when they found like the bone marrow is hypercellular, they can check the serum erythropoietin level and like these, okay. So simply polycythemia vera, what is there, what is going on in this one? Too much RBCs are there, right? So the symptoms are basically the symptoms of hyperviscosity, okay, in these patients, okay. And hyperviscosity is there, guys. What can happen? Simply uh, DVT can occur, right? Pulmonary embolism can occur, and so on and so forth. Like portal vein thrombosis can occur, right? So many other things. Budd-Chiari syndrome is there, and many things like, okay. So why? Because the blood viscosity is increased, right? Like, and there is increased platelet numbers in many of these patients who have polycythemia vera, and bleeding complications can occur, right, because of epistaxis, or all these things can occur. One thing is what you can say, something called as erythromyalgia. What is erythromyalgia? Erythromyalgia. Okay, like, what is erythromyalgia? It is basically burning pain in hands and feet. Okay, uh, with redness of the skin. Uh, One of the thing, one of a very important, you can say, feature of these patients is uh, the patients who have polycythemia vera, they have pruritus, uh, pruritus after taking bath. Okay, a very like a warm shower or bath, you can say. Why? Because they have increased number of cells. So whenever they take warm bath or cells, there is a lot of mast cells degranulation and histamine release after taking bath. So they present with a pruritus. This is a very common symptom, which the patient present to the hospital with. Rest, like, they have a lot of other features, okay, because of decreased or reduced blood flow due to hyperviscosity syndrome. They have many GIT problems. They may have gout because of hyperuricemia. Okay, their face become too much reddish type of complexion is there. Okay, we call this thing as plethora. Plethora, plethora, not thora. Okay, so like their complexion is changed. Okay, or like when you will see their face appear too much reddish. Uh, you know, because they have their hemoglobin level is too much high raised. Okay, so simply what is done in these patients, guys? Like, because of course the diagnosis is based on CBC and all the peripheral blood film, the count of the cells. Okay, so what is the treatment? We do is called as phlebotomy. We keep on withdrawing their blood until their hematocrit level is less than 40%. Okay, we they keep on taking out their blood until their hematocrit is less than 45%. Okay, this is the one of the thing. If there is a high chances of thrombosis, all those things, one of the drug hydroxy urea can be given to these patients. Okay, plus, because they are higher chances of developing all these conditions, we give them low dose aspirin. Okay, is given. Yep. And as you know, allopurinol for gout, or if they are too much itchy, antihistamines can be given. So this is the treatment of polycythemia vera. 10 to 20 years survival with treatment. Okay, so they have good chances, or good life, good what you can say, good time. Okay, so this thing is there. One more thing, guys, which is idiopathic myelofibrosis. Of course, like as the name shows, what is idiopathic myelofibrosis? Like, these are the people in which, like, there is bone marrow fibrosis, and when the fibrosis is there in the bone marrow, of course, there will be anemia, there will be pancytopenia. Simply, there will be anemia, there will be what you can say, all the cells line will be decreased, right? So that is simply, these are the patients who present with anemia, weight loss, fever, night sweats, and all these things. Okay, so in the next lecture, of course, I'm going to talk about a little about what you can say, idiopathic myelofibrosis with essential thrombocythemia, and then we will go on to the lymphoid lineage, and we are going to cover acute myeloid leukemia and acute lymphoblastic leukemia and chronic lymphoblastic leukemia. Okay, and then we are going to cover the lymphomas. Okay, and that's it. Like, then we are over, yes, and multiple myeloma, of course, we are going to discuss in detail, right? So that's it. Thank you so much for listening, guys. And in the next lecture, we'll start with the next topic.